Hello everybody, my name is Raisha Nurani. I'm a GP ST3 in London, and today I'm going to talk to you about managing a palliative care patient, an end-of-life care patient in the CSA. Now, I was asked to do this and I can completely understand why, because it's a sensitive and difficult area, and if you haven't had a huge amount of experience, it can make it very difficult to kind of work out what you're doing, and it can feel like a lot to handle in a 10-minute consultation. The other thing is it's usually part of a home visit, which means you're already a little bit fluxed because you're in a situation which isn't your standard, this is my GP surgery room that I'm going to have for the CSA, and you're taken to a patient who is unwell and at the end of their life. So I completely understand why it can be a stressful scenario to run. And hopefully I can try and make it a bit more simple for those of you who are concerned. So when we do palliative care, really in a CSA situation, you're going to have one or two, or maybe a mix and match of these two, but generally you're either going to look at symptom control, or you're going to look at how to manage end-of-life decisions, treatment escalation, and that sort of thing. So I think those are the two areas that I would focus on for CSA. Now, I don't believe that it's worth having a completely different structure and format for every single type of case you're going to get. Otherwise, it's just so overwhelming. You know, you can't learn a certain structure for every single case, so really I want to try and fit this into something that you would normally be doing, so bread and butter general practice cases, and not something you have to learn specifically for. So what I would say is there's history and there's management, and try and stick to the same sort of principle. Now, when you do history, remember that people with whatever reason that they at the end of their life will have a long history of medical interventions and things that have happened. And whilst it may be a good idea to consider, what's been going on and how this patient has traveled through their journey to become end of life, really the CSA is not testing that. And if you spend too long in this part of the consultation, what will happen is you won't have time to really manage this patient. And end of life is about management. It's about managing symptoms, making sure patients are comfortable, both physically but mentally happy that, this doctor is going to take care of them and they know what their wishes are. So when I take history, I think what would be important is we really focus on symptoms. So you may ask a couple of opening questions like, okay, please tell me about your diagnosis and how it led to this, and that might be it. And then I really can start talking about symptoms, because that's what your bulk of why you're there and what you can help with. Now, there are a number of symptoms that you can have at the end of life, and actually the way we manage them are probably a bit more free, because our priority is to make the patient comfortable rather than worry about the side effects of whatever medication we might prescribe. So first symptom is pain, that I always ask about. So pain, ask them what sort of pain they have, where it is, and actually remember, you don't need huge amounts of red flag. So what you need to know is how much pain relief, what are they on? How much are they on? Is it helping at all? Was there anything that helped? So you're focusing on really the symptom rather than, what could it be? Have they broken a bone? Have they, what is this pain related to? Because we all know what it's related to. And you're less worried about red flags because you're not really trying to intervene here. You're just trying to settle the pain. So you really want to focus your history on the current symptom and how you're going to manage it. Now, when I ask about pain, most patients will be on an opioid, which means it quite nicely blends into the other symptoms, which are the side effects of opioids. So do you get nausea or sickness? And then also, what about opening your bowels and any constipation? So really, you've now covered three of the major end-of-life symptoms. Other things that you might wish to ask about is breathlessness, or when they're lying down, if they've got increased secretions. So those are the major kind of symptoms that you would talk about. Those are the physical symptoms. And then what I also talk about is the mental symptoms. How are you feeling in yourself? Do you feel that you're getting enough sleep? Do you feel agitated or restless, like you might be doing something else? Agitation is really common at end of life, which is why you give midazolam very frequently in palliative care. So really, agitation is a nice one to ask with the mental side of things. So I hope that makes sense. So in terms of symptoms, we've covered pain, nausea or vomiting, constipation, shortness of breath or breathlessness, secretions, and agitation and mood. Those are the major things that you'd cover. Now, that's your history. And then when you get to your management, you're going to talk about all of the symptoms that are relevant. Now, apart from knowing what the symptoms are, you need to know how you're going to deal with it. So a couple of other questions that I would always ask in the history are, can you swallow? Are you having difficulty swallowing? Because there's no point in giving someone a huge amount of pain relief if they can't take the medication for it. So at this point you might be asking, okay, if they can't swallow, would a liquid be more preferable? Are we going to move on to patches? That's what you're thinking in your head. The second thing is you want to know how much, because if you know how much that they're taking in terms of symptom relief, then you can kind of work out in your management where this is going to lead to. So you need to ask exact amounts of how often are you needing the Oromorph? Are you taking, every 2 hours, more frequently? And then what you do is when you go to your management, what you're going to really say is, you're taking Oromorph regularly, which works very well in the short term, but in the long term we should give you something that's longer acting. I'll also give you Oromorph, so if you're getting pain, even with the longer acting, you've got something else to keep you going. That's if someone's able to swallow. The second thing you're thinking about, well, if they can't swallow, what do I need to do instead? And at this point, your options are really things like patches or a syringe driver, which could be set up by your local hospice. So that will be the other thing you might mention in management, going, look, I can see why you're in pain. You're struggling to swallow the pain relief. I think we need to find another way of giving you this medication. Have you thought, or do you know about a syringe driver? How does that sound to you? I can get the hospice to come out today and set it up, and then we can alter the doses depending on how you're doing. Those are simple things. So once you've covered the sort of physical symptoms and you moved on to the mental symptoms, so the depression, the agitation, the restlessness, the sleepiness, or lack of sleep, the other thing you might want to then discuss from once doing the symptoms is how that will lead to what happens next. So this is really, palliative care is special in the sense that you have the luxury, and the patient has the luxury to talk to you about their wishes and express how they want things to end. Now, I know a lot of people find this difficult, and I think it's worth having a few statements that you might have in your mind that you can use to start opening that conversation. So in the history, once you've done, the now, all the symptoms that you're having now, let's move to how things should go in the future, or let's look at the longer term view. Have you thought about how you want things to end? And that's really asking, do they want CPR? Do they have a do not resuscitate form? And also is asking how much intervention they're keen to have. Do they want to have blood tests? So if you ask how things should end, then that gives you a good idea of where things are at. The second thing you want to ask is where things should end. And this is important because this is telling you about whether you should be escalating this patient to hospital if they suddenly become unwell, if they would like to go to a local hospice, or if they just want to be at home. And I think those two questions are the ones that really help you make those decisions. So you're asking, have you thought about how you want things to end? And then if you were to die, where would you like to be? And that's a nice simple way of asking, do they want to be at home or do they want to be a hospice? And then if they say something, I'm not sure, and you can say, look, have you spoken to our local hospice? Let me do a referral and get someone to come and see you, and then you can talk about this in more detail. And at this point you're saying, okay, well, you've suggested, that you don't want to go to hospital if you get sick. And I think that, you can say, I think that's a sensible choice. So what I think we should do, and this is when you get to management, what I think we should do is we should look at maybe treating infections with just oral antibiotics rather than taking you to hospital and putting in needles and giving you antibiotics via drip. How does that sound? And then the last thing you're going to do in management, when you've talked about your symptoms and your end of life side of things, is you're then going to talk about how you're going to communicate that information, because it's all well and good having that conversation with the patient, but it's in isolation, and there is an entire team that coordinates its efforts to make sure that the patient gets what they would like. So if you were, for example, in a nursing home, all the staff would be on board. If it's a family, all the family would be on board. So things like, okay, I know we talked about not wanting to be resuscitated. I will fill out the form and leave it here at home, but I will also make sure the ambulance service gets a report of it, and we will put it on the notes. And it's really important that any time you have any contact with a health professional, they know that these are what your wishes are. Is there family that I can talk to explain what's going to happen and what you would like? So you've expressed how you're going to communicate that information, and that it's a team, a whole community that works towards that. Some of the things that you might say here is, would it help if I spoke to one of the family members and explained what these wishes are? Now, I think it's really unlikely in a 10-minute CSA situation to have to deal with all the symptoms and to deal with end of life, but you may get a few symptoms and perhaps a bit more detail on the end of life. You may get a shortened version of the same approach. I'm hoping that this allows you to work out what you need to ask in history and how you do that in management, and then the structure is not so far away from your standard taking a clinical history and examination, which you will do for every patient. If you have any questions, feel free to put them in the comments below. Please subscribe to these YouTube videos. They really help anyone who's trying to revise, and it comes up on their search when they're practicing for CSA. And if there's anything else you would like me to talk about or go through, then I'm more than welcome. Please put it in the comments below. Thank you very much, and best of luck revising.